Hello all, I am Selvasekar, Chair for the Northwest BAPIO. I would like to thank the whole of BAPIO family and the Northwest BAPIO for putting up a fantastic program for the mid-year virtual BAPIO meeting this year. I would like to introduce one of our keynote speakers, Dr. SWAMINATHAN. She is the Chief Scientist at the World Health Organization. She's an academic pediatrician who's been in the post for the last few years. I am delighted and proud that an academic Indian has been selected as a chief scientist for the World Health Organization as the first person to do this job. Unfortunately, Dr. SWAMINATHAN is not able to attend this virtual BAPIO mid-year meeting. However, she has sent a video which gives a description of the role of the chief scientist and the role of the World Health Organization in the current pandemic and also the work done so far. Thank you all very much.
Greetings from the World Health Organization in Geneva. I'm Dr. Soumya Swaminathan. I'm the chief scientist, and actually I'm delighted to say that, I'm the first chief scientist of this organization. After its 70 years of history, a science division was created in March 2019, essentially to ensure that WHO stays ahead of the curve, that we're leveraging advances in science and technology and making sure that those can be quickly translated into clinical and public health benefits, and also to bring solid quality assurance to all the normative guidance and data and standards that we put out, which of course are developed to the highest standards of scientific excellence based on a very thorough process. But we also want to make sure that these are relevant, that they're timely, that they address the end user needs, and that they are presented in a format that is much more user-friendly and easily adapted and implemented at the country level, which means moving away from paper or PDF to what we call computable guidelines, which also facilitates the whole concept of living guidelines so that one can update it as we go along. Many people have commented that the establishment of the science division last year was truly visionary, considering where we find ourselves in the middle of a pandemic in 2020. And the division has played a very key and central role in the response to the pandemic, both in trying to sift through the huge amounts and volumes of research and data that's been coming out in this in the past 9 months, and distilling the scientific evidence from that, making sure that it is systematically reviewed, that these reviews are updated on a regular basis, and that these then find their way into the guidance that we produce. We started producing guidance on the 11th and the 12th of January, right after we had learned about this new outbreak of viral pneumonia. And we knew also on the 11th of January that it was a novel coronavirus, because by then the sequences had been deposited in a database called GISAID. So for me, one of the really noticeable and positive things about the pandemic has been the fact that there's been so much of science and research and data that has been generated. I think it is quite unprecedented that on some days we are reviewing 500 publications a day. And if you add the preprints and if you add papers in different languages, then it's a huge amount, a huge output. Of course, it's of varying quality, so one has to also sift through to assess the ones which are of good quality and not so good quality. So that's one of the challenges. But the fact that there's so much that's being produced is fantastic. And the second thing that's been really positive is the spirit of global collaboration that I have seen among scientists, academics, researchers, public and private sector, willingness to share data and knowledge well before it is published, the willingness of journals to make everything that's COVID-19 related open access, and the willingness also for the private sector to work in a very collaborative way to a large extent with us has resulted in a huge amount of innovation, a huge number of clinical trials, the development of rapid diagnostics, for example, that can now be used by people in their homes, the multiple clinical trials, including the recovery trial in the UK and the solidarity trial run by the WHO, that have clearly tested therapeutics against a primary outcome of mortality, to make sure that our treatment is based on evidence that has been generated and is of high quality, and that we're giving our patients the best possible. And that's why I think we have seen the shift from the early part of the pandemic in March and April, when we saw very high case fatality rates in many countries, certainly in Europe, to what we see today, when the number of daily infections are almost at the same level that they were in March and April in many countries, and yet the case fatality rates, touchwood, are staying quite low. And that's for a number of reasons. Partly the age group of people being infected now, partly the much larger number of diagnostic tests that are being performed today, which means that you're actually detecting many more than you could have detected way back in March and April. And the fact that we've learned so much about the management of this disease, about the pathophysiology of this disease, that we are able to manage patients much better. And that's only come about because of this kind of sharing of knowledge. At the WHO, we had the first Global Research Forum in February, which brought together clinicians, academics, scientists, researchers from around the world to develop a research roadmap, which laid out clearly what the knowledge gaps were and what the research priorities are. And subsequently, there have been 9 working groups that have been meeting regularly, once or twice a week, in order to advance their own areas like transmission, epidemiology, infection prevention and control, diagnostics, therapeutics, vaccines, as well as a whole group that works on social and behavioral science, and another one which is around bioethics. And these 2 last groups have been cross-cutting in that they have got involved with elements of each of these other more technical groups, and brought the bioethics aspect or the social and behavioral sciences aspects to inform the work, as well as to raise questions and issues. Because we know that, and we have seen that behavior change is something that cannot be easily achieved just through providing information or updating people's knowledge. Behavior change does require a different approach, which needs to be informed by the behavioral scientists. So we've tried to have this interdisciplinary approach, including in areas like transmission of the virus, where again our understanding has evolved from the beginning, when we thought it was mainly through droplets and fomites, and then we started learning that the droplets can be of different sizes, and that some of them are small enough to stay as aerosol particles in the air for a period of time, and the fact that closed spaces, poorly ventilated, closed and crowded settings, are extremely high-risk places for infections to occur. So, of course, our understanding has evolved and our guidance changes based on the science. And another remarkable feature of this pandemic has been the huge amount of public information and interest, of course. And this is something we call infodemic, which is an information overload. And a large part of that, or a significant part of that, is also false or misleading information. And it is very difficult for a layperson to really distinguish between the two. And therefore, WHO has been, from the beginning, again, very much focused on making sure that we're working with all the big social media and tech companies. And they've been hugely collaborative and very positive in wanting to handle this problem, in wanting to remove sites and posts which are peddling misinformation, and rather taking viewers to sites which are credible, like the WHO, like the CDC, like the NHS, and so on. So that's been, again, an interdisciplinary effort at trying to manage, because on a daily basis we review everything that's going on in social media, and I can see how much misleading and false information there is. And sometimes, of course, we are quoted out of context as well, but most of the time it's purposefully done. Now, because today is World Patient Safety Day, September 17th, I would like to say a few words about this, because this is a new Patient Safety Day was created by the World Health Assembly in 2019. So this is really the first year that we are marking this day. And the theme for this day is Health Worker Safety, a priority for patient safety. And we have seen right from the beginning of this pandemic that health workers have been disproportionately impacted by this virus. We know that health workers constitute 2 to 3% of a country's population. In low and middle income countries, it's around 2%. In high income countries, it could be a little bit more. But the prevalence of COVID infection that's been reported to us has ranged from 10 to 14% on average to up to 35% in some countries. So we have seen also a large number of deaths of doctors, nurses, and other health workers in many countries around the world. And this has been one of the very tragic consequences of this pandemic. A recent survey also found that about a quarter of health workers who were surveyed had depression or anxiety, and about a third of them actually complained of insomnia. And I'm sure that many people in this audience would identify very much, and it would resonate with, I think, all of us, but more so for those who were at the front line and who were caring and are caring for patients. So the World Patient Safety Day is dedicated, as I said, to health worker safety this year. And there are a few goals that have been placed before governments and organizations that run health establishments. And these are to prevent sharp injuries, to reduce workload-related stress and burnout, to improve the use of personal protective equipment, to have a policy of zero tolerance to violence against health workers, to report and analyze serious safety-related incidents. So these are the 5 goals that we have proposed that the nations and member states and administrations adopt, hospital administrations adopt. And we also have the charter. It's a health worker safety charter where there are again 5 actions that have been proposed. And these are to protect health workers from violence, to improve their mental health, to advance national programs for health worker safety, and to connect health worker safety policies to existing patient safety policies. So these are some of the guiding principles, and I think hopefully if this finds resonance, this would help to a large extent in protecting healthcare workers, not just from COVID-19, but from other risks and injuries that we are all exposed to in the workplace. Finally, I think we are entering a new phase of the pandemic. We see, of course, different patterns in different parts of the world. We are crossing 30 million infections today. These are just the known infections. We know that there are many, many more which are undetected. We are coming up to 1 million deaths, unknown deaths again due to COVID-19 in the past 9 months. And we are now entering period where many countries are emerging from lockdown, they're opening up, people are getting back to work, people are getting back to school and college. And the Northern Hemisphere, of course, is entering the period of autumn and winter, which means more people will tend to be indoors than outdoors. And perhaps there's also a lowering of guard, a tiring of all the restrictions, and some complacency that this infection is not as bad as we thought it was. And all of these factors could lead to increasing infections, which are invariably followed by increasing hospitalizations and deaths. And we're beginning to see that happening in several countries in Europe. North America, Latin America have already been, for many, many weeks now, in a state of high transmission of infection. This continues to be very high in many countries, and the death toll is also very high in those countries. We also have countries in the Middle East and in Asia which are experiencing continuing high transmission in their populations, including countries like India, which of course have such a huge population that it's very challenging. So governments and individuals will have to make some tough choices and decisions. On the one hand, protecting livelihoods, protecting the economy, making sure that essential health services are operating, because we've seen the devastating impact of the closure of essential health services in most countries and how that's really impacted people, whether it's maternal and child health and immunization services or whether it's NCD services. So on the one hand, essential health services have to be maintained. Livelihoods need to continue because poor people have been, again, impacted disproportionately. The vulnerable, the poor, the minorities in most countries have borne the disproportionate impact. But at the same time, infection rates will have to be kept low. We know what we have to do. We know what the public health measures are that work. The physical distancing, the wearing of masks, the attention to respiratory and hand hygiene, making sure that you're avoiding these high-risk environments, the closed and crowded, poorly ventilated settings, ensuring that there's enough testing, diagnostics available to detect and isolate people who are positive and to track and trace the contacts and quarantine them. These measures sound simple, but they're not so simple to implement, and they require a lot of rigor as well as a lot of resources, human resources, as well as patience on the part of people. So I think we health workers, doctors, nurses, are in a good and a strong position to continue to advocate for these public health measures. And on the one hand, you need governments to stay strong and implement these measures. And on the other hand, you need, of course, individuals and communities to be empowered enough to follow these directives from the government and to cooperate. So we will need to continue to do that for the foreseeable future till we get enough vaccines. And I don't want to go a lot into vaccines, but just to say that tremendous amount of research going on. The scenario is optimistic, but just because there are so many candidates that are being tested, that hopefully several of them will turn out to be safe and efficacious. There are still many question marks as to the duration of protection, the safety of some of these new platforms, etc. But even if we have several successful vaccines, it's going to take time for the manufacturing scale up as well as the distribution and vaccination of large parts of the population. So we are looking at the rest of 2020 and 2021, where we will need to continue all of the measures that we just mentioned, in addition to vaccines hopefully beginning to be rolled out. And at the same time, we mustn't forget that there are advances in diagnostics and therapeutics, which will also help, which will also have an impact in reducing the burden of, at least the burden of the severity of illness and deaths due to COVID-19. So the WHO is very much at the center of this, of fostering global solidarity and collaboration, where we set up the ACT Accelerator to accelerate the development and the deployment in an equitable way of these new tools across the world. And this is a test of solidarity, it's a test of our humanity, and I think everyone will play a role in this, and maybe future generations will actually look back to judge us as to how we performed. So I want to apologize that I'm not with you in real time, and I'm sending you this message in advance, but I do wish you a very good deliberations and a good conference. Thank you very much.